primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Mariel Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care. Now, you guys are walking into this amazing conversation that has already been going on for a few minutes, but I am joined with some amazing people. Some of you listening already met them at DPC Summit. So please, my esteemed guests, can you please introduce yourselves? Dr. Garrison Bliss, we'll start with you.
Garrison Bliss. I am a retired direct primary care doctor. My major distinguishing feature is I was the first one. So I have been in all the trenches with many of you. And I was brought here to sound elderly, which is easy.
And in most recent times, he's also been known for being an esteemed pickleball player. So if you play pickleball, you are amongst great company. And Dr. Eskew, we'll turn the mic over to you now.
Phil Eskew, family physician and attorney, been practicing in the direct primary care space as soon as I could, which was as soon as I finished family medicine residency in 2015. Done that in the on-site space. Also got a correctional medicine background. Been working with Jay Keese and the coalition now for 10 years too, it's just flown by, and it's been a lot of fun. Amazing. And you are the counsel for the DPC coalition. So I think that it is so important, and Garrison has shared this before, that this movement be physician-led, because we do not want to get ourselves into the same fee-for-service situation that we are currently trying to escape left and right from. And so, Phil, it is so important that you are a physician. You are still a practicing physician with so many different places you've practiced. And so it is wonderful to have both of you continuously involved in this movement. Now, Jay, I'll turn the mic over to you.
It's a pleasure to be here with you all. I'm Jay Keese, and I am the executive director of the Direct Primary Care Coalition. Garrison Bliss came to me in 2009, I believe it was, and with his protege Norm Wu and a few other people, and asked for some help in the lobbying and policy world after they had actually already passed a bill in Washington State to sort of navigate what would become known as the Affordable Care Act. And so we started the Direct Primary Care Coalition, which Garrison still chairs, back in 2009 to help pass the provision that first defined direct primary care in federal law. And we have been active ever since in passing not only the provision that was in the act that first defined DPC as a part of the essential health benefits plan, part of the Affordable Care Act, but then passed state laws in 33 different states that define direct primary care as a medical practice outside of state insurance regulation. Phil, since almost the very beginning, has been our general counsel, not only a doctor, but an MBA and a lawyer. So we're really happy to have these two folks as the physician leaders of the coalition that have really helped us put together the policy agenda, which has really been quite unique over the course of the last 10 plus years. It's not easy to say you've passed all these provisions in a bipartisan manner in today's environment, but these are things that we've gotten the Obama administration, the Trump administration, and the Biden administration to agree on, that people ought to have better access to primary care. It ought to be paid for at a flat fee without insurance company involvement in terms of billing and coding and all the other things that go into, really making primary care more burdensome and more expensive, and just let the doctor and the patient make the decisions for primary care as they should. And here we are, facing a number of policy hurdles that we still have to fix and some new challenges ahead. Very excited to have seen the growth over these years, and super excited to have this cadre of great physicians that are really helping to bring better primary care to everybody in America in every setting: Medicare, Medicaid, private pay, uninsured. The entire gamut is really, all the boats are rising because DPC docs are there to help people really get in tune with their own health in a relationship that otherwise isn't available anywhere else in the American healthcare system. So sorry to ramble, but I'm passionate about this. I'm a patient. Dr. Matt Hayden here in Alexandria, Virginia is my doctor, and he takes good care of me. And it's just wonderful to be a part of this movement.
Wonderful it is. And we have literally the gamut of people who have been involved in this world for so long on so many levels, taking care of the patients all the way to policy. And I really feel that this talk is so important for people to hear right after Summit, right after, Phil, they've heard your lecture on the legal updates to DPC. And you've said this, but people still come up to you and say, oh, there's legal hurdles with DPC. And we will be talking about that today, not only through what is going on Capitol Hill, but also how you as a listener can become involved. So with that, I wanted to go back into the days before DPC. So Garrison, there was a time when we did not have primary care being the bottom of the barrel when it came to number of physicians going into primary care, when it came to the way that a primary care physician was valued by patients as well as employers. So can you give us a flavor for how things were before direct primary care?
In the dark ages, is that what you're saying? Well, yeah. Well, I started being a primary care doctor in a private practice in 1980. Finished my residency at the University of Washington and went out to earn a living doing primary care, which was something that I loved from the beginning. I thought I was pretty reasonably well trained. I listened to all the same talks that you folks have probably listened to about spending time with patients, about open-ended questions. And when I got out into practice, it really was like that. I love to spend time with people, and I really enjoyed the work. I joined a practice that grew pretty rapidly, but about the early 1990s, it was clear that we were going to go broke probably doing that, although not immediately, but we were easing our way up, and we were seeing enormous pressure to get better at the business because the insurance companies were not increasing our income as the cost of healthcare was rising, but they were increasing the amount of work we had to do. And I had some pretty stunning learning curve several years before that, when my 3-year-old son had a brain tumor, and I was able to experience what it's like to be the father of a patient rather than the doctor of a patient, and to watch how the healthcare system managed him in a very good hospital, probably the best children's hospital in the state, and with the right kind of medical care, but with not very much attention to the actual service part of the work, and also very limited support for parents. And then I started to look at my own practice and began to realize that maybe we were slipping into some of those problems, that we were trying to speed things up, and we were trying to figure out a way to stay cash flow positive, and we were struggling. And also the pressure was to see more and more people. And I decided that although most doctors had not reached any kind of breaking point, I had, and that I really wanted to break off and go do something different and better, and spent a lot of effort trying to think about how it could be better. And in particular, how big a panel was the right size of a panel, how much time should be spent per visit or per patient, should we see everybody every year, what kind of, try to figure out how to make it better, how to see people for urgent care urgently, and without sending them to the emergency room or to the hospital to get that work done. So to maintain a relationship with them in which they could trust you. So all of this stuff seemed very important to me at the time. And eventually I started working out the design, which also eventually included a question of how much would it cost, because I had already realized that insurance companies, as they existed then, even though they were paying much better than they are now, they didn't care at all about about how many minutes I spent with a patient or whether I cured them or anything. They were paying little attention to that, but they were increasingly trying to control the amount of money that they paid to us to do this work. And gradually we were asphyxiating. So after a few computations, it became clear to me that with a panel of 600 to 800 people, which I thought I could manage because I was pretty young and many of my patients were reasonably young. And I knew that I could do that. And with that panel, it would cost about $50 to $60 per member per month to do it. Two of my partners had just left to go start the first concierge practice in the United States, which was MD Square, at $1,000 per member per month. That used to sound like a lot, but it's apparently not anymore. But that was the first really concierge practice. And I thought I liked the monthly fee, but I didn't like the rest of the baggage. I wanted to take care of everybody. And I wanted something that could scale to take care of everybody. So Seattle Medical Associates switched from being a fee-for-service practice in 1997 to being a monthly fee practice. And then as time went on, we discovered that we had to figure out a way to teach other people how to do this because it really worked way better than we thought it was going to work. We suddenly discovered that as good as we thought we were like 3 times as good when we had the right panel size and the right amount of time with patients. And the patients loved it and we loved it. And I didn't see a reason why the rest of the country couldn't do that too, because it wasn't expensive. So anyway, after that, we started forming national organizations to start to understand this. It was called the American Society of Concierge Physicians, and then morphed into the Society for Innovative Medical Practice Design and several other names along the way. And then direct primary care was created as a descriptor so that we could pass a law in the state of Washington where the insurance commissioner thought that we were illegal, flat illegal, and that he was going to start closing our practices, and we didn't come up with an argument. So after that, it's just kind of progressed along. I'm not going to go through the whole history, but I do want to just let you know that healthcare has been getting gradually worse since then. It's now a kind of almost a sordid affair to watch it going on as doctors are running as fast as they can to get their coding right and to see more patients than they ever saw before. And as all of the middlemen have stepped in to help us out and suck up the money that's going into healthcare. And the insurance companies have just figured out what makes money for them, but they haven't really decided yet a way to get actual first-rate care to human beings. So we're doing that, and it's scaling remarkably well across this country right now. We're no longer a secret. And we're even beginning to encounter policy people who think they invented the idea and think maybe we should try this now. So there's a lot of cool stuff going on. And there's a possibility that the vision that I had prayed for and hoped for, but never thought would encounter, might actually come to place, which is that the vast majority of people in the United States could be getting this quality care, and the vast majority of primary care doctors could be having this kind of a life, and it would be affordable, and it would save the country 20 to 30% of what we're spending right now, which would be a bloody miracle.
And so, Garrison, this is where I want to ask you to give people a rundown of Qliance and the experience there, because people are not familiar with Qliance as much as they used to, just based on time since Qliance is closed.
Let's see. Well, we opened in 2007, I think. And the first thing we ran into was that we needed to find a way to get somebody to invest in our company. And they didn't like the fact that we were being threatened by the insurance commissioner's office. And so we had to pass a law in the state of Washington. And then we heard that the Obama administration was going to create a vast healthcare system, and that there was a distinct possibility that they would do something that would undermine what we were trying to do, because they were considering making primary care free without making primary care doctors solvent, which is a pretty wild concept. But that was really on the table. So we had to get busy in Washington, D.C., and that's where we met Jay, which was a match made in heaven. I gotta say, this guy has stuck with us through thick and thin, and we've given him plenty of challenges to take on, including the 33 states that now have laws. And so we are making real progress. The healthcare system is not, but I think it could with proper support from primary care.
And clearly, everybody on this call agrees with you, and the listeners are probably shaking their head in agreement too. I want to bring Phil in here because in 2016, you responded to an article that the American Academy of Family Practice had put out, and the article was entitled, "Is Direct Primary Care the Solution to Our Healthcare Crisis?" And the physician, who is a CPE, was commenting many things that you responded to in your article in defense of DPC. But the reason I bring up Qliance, and Garrison, thank you so much for that little, the little crumb of what Qliance was and how it helped people, because Phil, I want to just go into the things that Garrison, you can talk to in terms of what Phil is speaking to in rebuttal of this original article was true even before this article was written. So this doctor is stating DPCs exacerbate the growing physician shortage. And so I'm going to read you the things that are very commonly heard in terms of criticism of direct primary care. So number one, DPCs exacerbate the growing physician shortage. DPCs are essentially unregulated insurance, capitating physicians and removing vital patient protections. DPC relies on an erosion of medical benefits. DPCs exacerbate disparities in care. The conclusion to this article was the wrong solution to a real problem. So Dr. Eskew, brilliantly, in defense of direct primary care, wrote that none of that is true. So Dr. Eskew, can you please talk to those points? Because your perspective and this doctor's perspective, again, we're even coming out after Qliance had already been in operation for almost 10 years. So that is where I wanted to go next. So Phil, I'll turn the mic over to you.
In terms of shortage, there's probably a physician shortage broadly, number one, but there's disagreements on that. The biggest problem is the maldistribution. And if you want to get physicians to do primary care, it needs to be appealing again. And this makes primary care appealing. This lets you become the Dr. House, if that's who you choose to be when you watch, whatever your favorite, or Marcus Welby, pick your one side or the other. But the point is, they had interesting cases. They had hard problems that they got to solve. They didn't have a list of 10 urgent care things that's all they saw and they referred if they couldn't answer your question in 5 minutes, which is what the insurance companies want to turn family medicine into, some narrow scope waste of time. And we're pushing back against that. And the reality is, if everybody actually pursued broad scope primary care, we wouldn't need as many specialists. So a lot of specialists would be motivated to come back into this, and we would do it better. Other countries do it better. In the United States, I think it's 30-70 and right now in terms of primary care to specialty representation, and other countries are closer to 50-50, which is where it should be. If you want to look at what makes somebody live longer, well, stopping smoking makes you live longer. Not having an alcohol problem makes you live longer. Does having a cardiologist or a nephrologist or a pulmonologist or an ophthalmologist make you live longer? Statistically, no. Having a family doc does. And that's across the world. That's not unique to the United States. So this draws people back into family medicine, and it draws specialists who wanted to silo into an area that maybe we don't need that many people siloing, to broaden their own scope and move back into their, especially for internists, back to their primary care roots. Calling it unregulated, how many times has a healthcare regulation saved somebody's life? Is the first thing I think of. It's the person doing the regulating here is the patient. If the patient's actually dictating their own care and involved in spending their own money for their own care, then they're making sure it's quality, or they wouldn't waste their money on it. The only time we need a bunch of regulators is when a third party's doing it, and now you have some, Veblen good problem where you've got a patient wanting to pay as much as possible for something because it's really not their money. So we bypass all that. And I think the attack there is an older one, and what I would say a better attack would have been, that I think we're getting better at as well, is how do we know they're doing a good job? And the answer is downstream data. And there's more and more of that out that tells people how good of a job we're doing. But the temptation, if you will, for a lot of new DPC practices, especially when they're working with employers or groups that want data, is how do you communicate that in a way that's realistic? Because if you use the wrong codes that are out there that are designed for fee-for-service, they're going to ultimately be used against you or create so many inefficiencies in your own model that you're trying to prove how efficient it is and ruining it in the process. Erosion of benefits. Should third parties be involved in paying for primary care? I'm not so sure they should, not if it's affordable. There's some people that can't afford gasoline and some people that can't afford food, and we have ways for them to get around on public transportation, and we have ways for them to get food even when they can't buy it. And we should look at those models when it comes to paying for primary care. But the biggest secret of all is it's affordable. For the vast majority of people, if you let it exist, it's affordable. And then exacerbating disparities, no, that's absurd. Hang out in a DPC office and you'll see everybody. If you come to the office I work at in Malden, South Carolina, you'll see it looks like the Village People, because you'll have police officers pull up, you'll have firefighters pull up, you'll have people that are delivering picking up the garbage pull up. We have all kinds of city employees. We have people that have no insurance, that we're all they've got, and they signed up on their own or their employer just covered that. We've got people that are through some churches in the area that have the most creme de la creme plans you've ever seen. You really don't care what the price of anything is. So we do see everybody. And the reality is DPC patients are for the most part the ones doing the selecting here. So if anything, I think our patient populations across the country probably tend to skew toward at least the activated patient, if not also the sicker patient. So we're not cherry picking patients, they're cherry picking us.
And
amen. I want to say the amen to that. I think that my experience was that the people in my practice who wanted to join me were either the ones who were my biggest fans or the ones who needed the most care, who couldn't get what they needed anywhere else because no one else had time for them. And that's the draw of this practice. This is not cherry picking. This is the real stuff, and it can be purposed for that, and has been. If you could ask Rishika about that, I mean, that with Boeing, with the sickest people at Boeing, they had a special practice just for them. So you can design this for all levels of people, from the youngest to the oldest, the most wealthy to the most impoverished. It can work in all of those districts.
And especially if you're new to the podcast, I definitely would encourage you to check out the other episodes that are on this podcast, because we have physicians sharing exactly what you guys are speaking to in practices of today, right? We can use telemedicine because we can use, in-person visits because we can use clinics that are on site, near site, just like you're at right now, Phil. There's so many options, and this is how DPC can be personalized with still, practicing evidence-based medicine and still, serving all populations. There's people like Dr. Angela Bymaster, who has a nonprofit as well as a for-profit branch of her DPC. And so she's able to take care of some of the poorest people in terms of fiscally poor in San Jose in a 10 by 10 block radius. There's people in Dr. Kiesel, who talked at the DPC Summit, one of my former attendings in residency. She is at a practice where her people who do pay a little bit more, so that anybody who shows up on the doorstep can get care without any questions. They get the exact same doctor. There's people who service communities at a higher price because they can take care of the other people in San Francisco. So there's so many options for people to know. And I mentioned those three in particular because when I talk to residents especially, a lot of people are saying, well, but DPC is concierge medicine. But one of the things that I wanted to ask is, were you restricted at Qliance because of coding, like in the fee-for-service world?
So Qliance was a lab. So when I left Seattle Medical Associates I moved my practice over to a new startup. I had some ideas about what I wanted to do, but what I really wanted to do was to make it a center of innovation in what we're calling direct primary care, but we weren't calling it then that at the moment. And so what we were trying to do was to find a group of people who would be willing to come join us in our experiment. We were trying to figure out who was interested, who would our customers be. We were trying to figure out what kind of services could we provide. We were trying to figure out what kind of price would keep us stable, floating, and growing without being unaffordable. to the populations that wanted to use us. And we've developed some serious investors who wanted just as much as we did. The first investor was a guy named Nick Hanauer, who was also the first investor in Amazon. And he was a guy who said that he was interested in disruptive startups, and that he considered healthcare the Mount Everest of the need for disruption. There's no other business in this country that needs disruption more than this. They need to be refocused on taking care of patients. They need to be refocused on taking care of all that patients have needs, including their financial needs. And so we invented some ideas. I mean, a lot of you now have incorporated some of those ideas. One of them was to give away medicine. Originally, we decided to set incentives to look at incentive design, for instance. So we wanted to make sure our physicians were not incented to either do more things or do fewer things based upon how much money they could make. That was really important. We also wanted a contract between us and our patients in which we made promises and they just agreed to pay for them, so that we weren't just saying we would try to provide the best care that could be provided, which is kind of vague and generally means that you're not working very hard at anything. But to say we want to provide the affordable care and with superb service, with rapid access. We wanted people to be able to reach us day and night. We wanted people to be able to reach their own doctor whenever possible. And we wanted doctors to have longevity with patients so that we knew them, so that we could be of use to them when they did call us. And we wanted to reconsider all of the services that we provided. So that eventually turned out to be things like finding discounted cash colonoscopy, and providing the lab work you got with for your annual exam in most places, which they were charging $150 for, we could get it for $10 cash. And we could do an x-ray in the office and it would cost the patient $10 because that's what it cost us to get a radiologist to read it. So we tried to live on our monthly fee and not have any other cash flow that would encourage us to do more than we should. That turned out to be a great thing. Doctors loved it, patients loved it, but then we had to find a market for it. And that was the hardest part because employers are responsible for most of the market in healthcare. Government is the other big chunk of that. The government, from the state government to the national government, pretty much looked at us like they were looking at Satan, because we weren't going to be doing things the way they do them. We were offering to have them. Nobody would pay the monthly fee, and I think that's largely still true in the United States. But we said the patient will pay the $50. All we want you to do is allow us to be preferred providers, so that we'll be able to order all the other things and handle their care without disruption. So we worked through a lot of those issues, and we got a long way. I don't think we have time to talk about our interface with Medicaid, which actually brought us to the ground. But that was mostly because we weren't aware that Medicaid did not pay for all the things I just mentioned. Medicare, even they would not even pay. They were paying like $10 to $15 to $20 per member per month max, which you couldn't run the office on that. And you certainly couldn't run a good office, and you couldn't provide enough time with patients. And then when we showed that we were able to do this for $50, if they would pay us $50, they decided that we were so good at taking care of people that they weren't sick anymore, which meant that they should pay us yet less. And that pretty much brought us to a halt, given that we had 30,000 Medicaid patients by that time and no way to go back. So we were both evidence of the possibilities of direct primary care, but we were also evidence of the potential dangers of of playing with some very tough financial forces without being fully ready to handle that or knowing how to handle it. So we definitely took a few punches for the movement, but I think what we learned has really helped open up the possibility of serious growth across this country, because we've learned so much about what we can do and can't do, what we should do and shouldn't do. And I think we are still ready to engage with some of these huge problems, but on our terms, not their terms.
And this is why, again, it's so important that you guys are sharing and speaking today, because we are at a point where, you know, you may have heard about this a little bit in Dr. Aiken's podcast that just recently aired the last couple of weeks. But Dr. Aiken, myself, Garrison, Jay, we were all doing some lobbying for the direct primary care movement, sharing our stories as individual physicians on Capitol Hill, and it matters. And Garrison, what you mentioned, what happened with Qliance and that Medicaid, you know, cut the legs out from under you guys really at Qliance because of not valuing what amazing care you guys were delivering. If you want to hear more details, definitely listen to Dr. Erica Bliss, your cousin, who was also with you at Qliance. She shared about it in the 2018 DPC Summit. That if you go to her episode on the podcast, there's a link to that video there, and definitely watch it for more on Qliance. But the reason I also appreciate this, Garrison, is because we're at a time when, you know, on Capitol Hill, we are still filled with optimism, and optimism in a way to guide direct primary care into the future with physicians at the forefront, so that we do not build a fee-for-service system going forward. So now, Phil, I'm just pulling up what you have on the DPC Frontier. So this is the website that Dr. Eskew created from nothing, and it's an amazing resource that anybody can use. But in the resources tab under DPC defined, for a practice to qualify as a direct primary care practice, the practice must, and I'll just read this for people if they have not looked at it or haven't looked at it in a while, charge a periodic fee, not bill any third parties on a fee-for-service basis, and any per visit charge must be less than the monthly equivalent of the periodic fee. So when you spoke at DPC Summit about, you know, the legal status right now of direct primary care, can you speak to how you hear Garrison's words, you know the history of Qliance, and how you are still able to be optimistic about DPC, even given the current state where not all states have legal protections for direct primary care?
We followed a little bit in the footsteps of some other entities that have not been insurance over the years, namely health shares. And they actually didn't pass laws in all 50 states either. They passed it in enough that even the states that didn't have those laws on the books, the insurance commissioners kind of looked next door and they said, oh, okay. And then the aggressiveness faded over time. And I think we've experienced the same thing. I get emails from all across the country from various physicians, you know, investigating doing direct primary care or early in the process, or even those that have been at it a while. And they do ask me sometimes some insurance commissioner related questions. The only two that have had any aggression that I've caught wind of lately were in Washington, which actually has law on the books, but the office didn't necessarily like the law that they had on the books. And then there were some whispers in Pennsylvania, but not so much, you know, direct impact in any meaningful way. And I always have to remind people that the 3-part definition you see on the website there, it didn't just come from me. That's early conversations with others at the DPC Coalition, when we've tried to clarify what this was really simply. And I think the time we put that together, there were only 4 or 5 states with laws on the books, and several of those laws weren't really that good, and they've subsequently been improved. And the third piece always gets the most questions around it. Why does any per visit fee have to be lower than the monthly fee? It doesn't have to be. You can go ahead and make that per visit fee much higher. But if you do that, you're not going to get any attention from the insurance commissioner. Ergo, you don't need to be defined as DPC. Do whatever you want to do. But if you want to focus on the incentives that the DPC model creates for ongoing care with patients, and also not get that wrong attention, That's the reason for the definition.
And we see this with the movement growing like crazy, that when we invest in our patients and our patients invest in us. Garrison, you spoke to this so well, that you guys were invested in your patients and you manifested a practice that was carrying 30,000 Medicaid beneficiaries. That to me, it just speaks to how a lot of the myths about direct primary care, or the misconceptions, are really proven false by each and every one of the practices that are open today and will be opening, especially after an event like the DPC Summit. Phil, as you speak to how we can still be effective even if we don't have DPC laws, there are two bills on Capitol Hill that are hot and going crazy, in terms of one that we were speaking to in February has already passed the House unanimously, and the other one is hopefully going to be in the September package. And so, Jay, can you please tell us about what are these two bills and how can we help using our voices to protect this physician-led movement going into the future?
So I feel inclined to go back a little farther than this month, since I've been involved since 2009. But let me go way back and go predate Garrison to the 1950s, when we had two nonprofit insurance companies spring up. One was called Blue Cross, and Blue Cross was designed to make sure you were covered anytime you go in the hospital, because when you go into any country in the world, you see a cross, and that's the sign for a hospital. Blue Shield was designed to shield you from problems that might arise, financial problems that might arise from your healthcare, and it was designed to shield you from your doctor. The whole idea behind Blue Shield was it was going to be insurance coverage in case your doctor charged you too much. Insurance companies were going to regulate that through the practice of insurance, and in some ways, it had a little bit of a rationale to do that back in the day, since the practice of medicine was largely, sort of unregulated. Today, I would counter the arguments that were made earlier about the practice of medicine not being regulated by saying that every single state in America has a board of medicine, and that anyone who's licensed as a physician, practice primary care, is licensed by that board of medicine. And what the provision in the Affordable Care Act originally said was that the practice of DPC, in the term of art was used in the ACA, of the direct primary care medical home, which was a DPC practice, was defined by the law that Garrison mentioned that was passed in Washington State, and that, it's not the business of insurance. It is a medical practice regulated by the existing laws and the boards of medicine in those states. You are, in fact, regulated by the Board of Medicine in the scope of your practice, which is primary care. There are rules about what you can and you cannot do. They've been on the books for a lot of years. So we've never really sought to change any of that. What we did run into when we passed the Affordable Care Act, of course, is states that needed to update their rules, their regulations. And one of the reasons we don't have rules and regulations in every single state is that some states didn't really need to update them. They synced fine with the Affordable Care Act. Some decided they didn't want to and have sort of just said, go and sin no more. But for the most part, what we found is that in almost every state we need it, the regulatory status is there in the Board of Medicine. So what we've done is we've removed the insurance commissioner and all of that administrative burden that's put onto the practice by taking DPC out of that, in both, a practical sense by removing the fee from fee-for-service insurance reimbursement, paying it up front like you would buy any other product or good or service, and having a relationship with the people you're getting the service from through DPC. So fundamentally, we've changed the equation from buying widgets, buying, episodes of care, to creating a payment structure to build a relationship with a professional who is Garrison Bliss or Phil Eskew or Mariel Concepcion. And fast forward, we've done a pretty good job. And I think I would argue that COVID was a major validator of DPC, because while the rest of the country was trying to figure out a way to get care, and the federal government was busy handing out checks to bail out fee-for-service doctors who couldn't see patients for a visit and therefore couldn't get paid their $115 for a 99124. DPC doctors answered the phone every time a patient called or did a Zoom call like we're doing tonight to figure out how to take care of people. Because candidly, you know, most of the things you guys do, you don't need to lay hands on the patient to really do your stuff. You need a conversation with your patient. You need time. And DPC has allowed you all to do that. And I would now say there's really only 2 regulators in the world that still define DPC as either some form of insurance or something that, you know, is above and beyond your means, right? And so the first would be the IRS. So when it comes to the almost 50% of people in America who have or are eligible for a high deductible health plan that's paired with a health savings account, due to anachronisms in the tax code that haven't been changed since, the IRS still defines what you all do as some sort of other coverage or insurance that makes an individual ineligible to fund an HSA. So if you have an HSA and it's funded, fundamentally, you're not allowed to have a relationship with a DPC doctor. Probably the most wildly not complied with law in tax code history, but it's a problem. It's a particular problem when it comes to trying to, stitch together a network of DPC docs that will take care of patients that an employer offers, and that employer happens to offer, a high deductible health plan that people have an HSA that's paired with. So we have a bill, the Primary Care Enhancement Act. It's HR 3029. It is passed out of the Ways and Means Committee in a bipartisan vote, awaiting consideration, hopefully in a package that will come together at the end of this year. And so we're excited about it. We think we can change the law. The law simply creates an exception for direct primary care practices that charge less than $150 a month, which is 98.9% of direct primary care practices. We realize it might cut some high dollar practices out, but it basically says if your practice fits within these guidelines, then the tax preferred dollars that are going into the HSA are going to be fine for the patient to contribute to the HSA, and the patient will be able to contribute dollars out of that HSA to you. And so nobody's a stranger to this bill. It's been up for a couple sessions in a row. We've never had more momentum than we do now, thanks in part to the group that was up on Capitol Hill this spring, lobbying really hard for that. And we have another bill that would allow CMS to create a rubric for primary care, direct primary care in Medicaid. And as Garrison mentioned, we had a lot of learnings to share with CMS and the Medicare agency about how, we could interact with DPC. One of them was that there would need to be an immediate upfront 3-legged stool where the managed care provider that manages the Medicaid contract in the state and the DPC practice would all have to agree on what is primary care and what is going to be paid for in a monthly fee and what's the value of that monthly fee. Then finally, there would have to be a 3-way agreement between all of these people and the Medicaid beneficiary that says, Garrison and Phil, these are your doctors, and you're going to go see them before you check into the urgent care or the hospital or seek some other level of care. So we're excited about that. That has not only passed the Energy and Commerce Committee in the House, but it passed the full House of Representatives a couple of months ago in a unanimous vote, very rare for a healthcare issue these days, and is moving along. So we're pushing really 2 really great bills down the pathway. And then in the midst of all this, what's the other big agency that we've left out? We've got the IRS for HSAs. We've got Medicaid. Well, Medicare. The Senate Finance Committee has recently put out a request for information about ways to move to a flat monthly fee payment for primary care services. Well, lo and behold, we've got an idea for you. I don't think any of that is a coincidence. I think they've seen what happened with DPC during the COVID period. They've read the Milliman study. And, if you don't believe us that we save, 20% of the total cost of care, believe the Society of Actuaries that actually says if employers front load a employer sponsored benefit with direct primary care, they save, up to 20% of the total cost of care versus the patient that's just in the regular old PPO. So we've spent a lot of years pounding the pavement on Capitol Hill, Phil and Garrison and I together, and Mariel and others and people that are new to it, to really bring people to this level of education where candidly we used to spend, you have a half an hour in a meeting, you spend 20 minutes describing what direct primary care is, and then you don't have any time at all to ask what you want to ask, which is make it legal for HSAs or put it into Medicare or put it into Medicaid, and don't screw it up, like whatever they ask is. Now we walk in and they're like, oh, direct primary care, that's great, we all love it, how do we get that, and what can we do for you today? And so, the what is for all of you physicians out there that are listening is, we want you to join us at the Direct Primary Care Coalition and come and lobby with us. We have our next fly-in coming up September 10th and 11th in conjunction with the Health Rosetta Fest. And by the way, the employers love this. It saves them money. So the employers, the brokers, they're all going to be in town lobbying to pass these bills that we've worked really hard to push these rocks up the hill. And we're getting a lot of traction now. So, we're in a very good place where people understand the value equation of DPC. I think they want it. And now it's really up to the physicians of America to come to the table and, really push it across the finish line with these couple of policy provisions. So, what it is we're doing this fall, we're looking at improving the ability for people with HSAs to get DPC, improving the ability for people in Medicaid to get DPC, improving the ability for people in Medicare to get DPC. We think everybody ought to have it. I actually long for the day when DPC isn't DPC, it's just primary care. We can drop the D because this is the way we deliver it, because it's the best way.
There's a lot of head nodding there. And, it's very interesting because just reflecting on the time in February in DC, it was very interesting to see that two of the top employers in the nation, Amazon as well as Boeing, were sitting across the table. Well, their lobbyists were sitting across the table from 10, 11 independent doctors. And, I think about how, Garrison, you made the point earlier about how so many people in this country are relying on their employer to provide healthcare. And something that I heard yesterday at the Chamber of Commerce event that I went to was that employers pay for employment engagement. And when a person is engaged because they're healthy, that's a lot of overhead not lost because of a patient being sick or a patient raising the cost of healthcare for the entire company because of their needs not being met. There's so many ways that employers find this movement very, very appealing. And that's why Rosetta Fest has had over 750 people attending last year, DPC doctors, as well as people who are wanting to build plans around DPC doctors, because people are recognizing that this movement is so important. So one of the things that is a big concern going forward in this movement is not losing our autonomous practices and being able to spend the quality time we need to, and for us as physicians to determine that time that's needed to take quality care of patients. I would love to hear, Phil and Garrison especially, your take on these two bills in particular, and how to continue going forward such that a physician, if they wish to, can still be successful and not have to code and still be able to serve a person who has Medicaid insurance or Medi-Cal insurance.
Yeah, I think I can answer your question to some extent. First of all, there's nothing we're advocating that insists that everyone has to do it. So this is voluntary stuff. And the early adopters for direct primary care have largely been very independent people with very strong beliefs about how it needs to be done. And that's fine. That's perfect. That's the vanguard. And that's also a model we think can go forever, particularly in places where you don't need scale. It's one person can only take care of so many patients. Once your practice is full, you don't have to change it, and you probably shouldn't. But I think that that as this movement grows and we start to take care of more and more people, I think we need to look at ways to maintain the culture. Because the way I define direct primary care, which is different from all this monthly fee and no fee for service, I define it as a culture of care focused on patients, in which patients have control, and we know who we work for, regardless of where the money comes from, and that we get enough money so we don't have to be thinking about money. We don't have a way to make more money by doing stuff to you or not doing stuff to you. This is an extension of an ethical concept about how healthcare should be practiced. And if we can find a way to do that without Medicaid or Medicare messing us up, then I think we should be looking at it, because they have the patience. Employers are a great source, but we have to break down the barriers there, which is what one of our bills is about. But the Medicaid bill is about making this available to Medicaid. I mean, the Medicaid bill that we've got ready to go, and Medicaid patients probably can't pay the monthly fee. No, they can't necessarily pay what it would take as a group. So this is a place where the government can be helpful, but it also needs to know that we're not going to play the way we've been playing with Medicaid, and Medicaid's not going to play with us anymore either. So we're going to tell them what it costs to do this right. They're spending on average about $800 per member per month nationwide for Medicaid patients. Well, if you can pay us 150 or 100 even, then we can make that number come down from 800 to 600 magically after the money you've given us. That's what we're offering you. So it's a deal for you, but it also allows us to say, you don't get to tell us how to practice. And if you want to collect numbers, feel free, collect your numbers as you wish. But we are not necessarily here for the purpose of spending our time writing notes to satisfy your need or collecting your data for you, because that costs us time and money, both of which we can't afford if we're going to do our first job right. So I think that this movement is now tougher and smarter than it was when I started. So we know where the bodies are buried. We also know where the weaknesses are in our relationships with governments and with some employers, and we're able to. And they're beginning to understand how important it is to preserve this kind of care, which is delicate and has to be done right and has to be adequately reimbursed. And then you have to get out of our way and let us do it.
And Phil, can you speak to what Jay mentioned earlier, the $150 spend with a patient's HSA?
That's been in there. That's been in several of the versions of the Primary Care Enhancement Act for years, and it was mainly there to get a score. We all sort of hold our nose with that. And as Jay pointed out, for 99% of practices, it doesn't matter. For the ones that have a fee higher than that amount, odds are if you ask their patients, they don't give a darn, because they were already either not worried about their HSA and just using it to, save money and didn't think that there was a tax risk or some other reason. It's not, that price point isn't one that's hitting employers, which is where the biggest pushback is right now on HSAs. So to Garrison's point, I think Garrison, even more than most, knows exactly how problematic Medicaid can be, especially when it's a Medicaid managed care company. And are you dancing with the devil by talking to them? Maybe a little bit, but you don't walk away right away. You try and get the details right. You try and show them patiently, carefully, how this needs to be done. And that means you don't walk away from the table at the beginning. You have the conversation, just like we have the conversation with Medicare, and we've had it repeatedly, and they've tinkered with various pilots in the past and sort of botched them, and we didn't participate. But one of these days, they won't botch it, and then that'll be really neat. And if you're not around to help them get it right, then that whole process is going to take longer, or maybe won't happen. So we're trying to get those things to work, and that's maybe the hardest part of this. I think we're pretty close to having the tax issues corrected, and arguably the HRA and FSA piece already are corrected, and it's mainly just the HSA that's still there. But then the question is, what do you do with Medicare and Medicaid? And you either watch them go bankrupt or find some much better solution, kind of what we're talking about here, where suddenly the patients care about price again.
Yeah, and I think we're at a pivot point in our conversation with all of these agencies where they've seen the data, which is really important. They understand the results both intuitively and from a perspective of the value equation that's being lost. Actually, hearing tomorrow in the House on how well has the CMS Center for Innovation done, and the reality is a lot of the programs that they've put forth have not saved a lot of money for Medicare and improved care in the Medicare program. So, and in 2015, we put MACRA in place to try to, push people to advanced payment models. And lo and behold, here we are almost a decade later, and the framers of MACRA, the very same people who wrote the law on MACRA, are looking to what might the next idea be. And those very people are saying, well, we think we might want to try out just a flat monthly fee and see how that goes. That's a great idea. I'm so glad you came up with that idea, and we're going to help you come up with that idea. So we are actually, as we speak, with consultation from the key members of the Direct Primary Care Coalition who have been to DC to do the lobbying and do the work, putting together a set of responses that say, not this is the way you have to do it, but these are our experiences. If you mess up the monthly fee with a lot of per visit fees and shared savings and risk adjust this and that, you're still going to drive misaligned incentives to see or to not see patients. And the whole idea here is pay Garrison $150 a month and let him take care of you, and watch the amount drop from the money CMS is spending in Medicare. Look at the Medicare claims data, Medicare downstream, and compare it to the patient who's got the DPC to the patient who doesn't, the same way Milliman did for the Society of Actuaries a couple of years ago. And let's see what happens. And I think that's really what's on the table for Medicaid and Medicare. In Medicaid, it's a little more complicated. So the bill, just so people understand it, the way the bill is drafted is it brings stakeholders together to sit around a table, and by name, including direct primary care physicians, to have a discussion with the Medicaid managed care establishment, with CMS itself, and with the states on what might work best in each state. Obviously, a Medicaid program in Idaho is going to be different than a Medicaid program in California, is going to be different from a Medicaid program in Maine and a Medicaid program in Oklahoma. So it's the states that will drive these things. And CMS has now been instructed by Congress to say, hey, let's sit all these people down at the table and figure out the right way to do it. But let's make sure the DPC doctors have a seat at the table. That's what's at stake. And Phil mentioned the score. Because it doesn't really mandate a program and say, hey, CMS, you got to pay for this, it has a 0 score. So it's a really good idea, again, to figure out a way to do this. And yes, you're going to have to compromise a little bit. Will you have to report on some measures? Maybe. We like the person-centered primary care measures that have been developed by the Larry Green Center. We've proffered to CMS that they use those as a way to measure whether or not you're satisfied with your primary care. Lo and behold, CMS really loves that and wants to use them. So, because they're good and they measure things that are of value to the patient. And a relationship with a primary care doctor is of value to almost anyone. I would ask you, what would you rather have? A health benefit that allows you an engagement that's going to make you pay money to an insurance company to potentially cover 80% of your care, and you're going to have to cover 20% of your care? Or would you like a free membership with a primary care doctor who's been through umpteen years of med school and had umpteen years of practice behind his or her belt to guide you as a Sherpa through the complicated web that is our healthcare system today. That's what you're getting when you sign up for direct primary care, beyond just great care from a doctor. So people get that. And I think we're at a major pivot point where policymakers, both at the state and the federal level, say, hey, how can we take the gloves off and let this thing flourish? And that's what we're trying to do. It's not going to be perfect. It never is. But we do promise we will never support anything that will mandate that you have to do whatever the man says.
Now, any last minute words for the audience that you guys have to share?
We've been at this for a long time. We want to make sure that you all know that you are welcome to help us and to get to, because somebody's going to keep pushing this rock up the hill for a long time, long after I'm gone. But one of the things we'd like you to think about is participating with Direct Primary Care Coalition in whatever way you can. But mostly we would love to have you come and help. dpcare.org is one place you can go to volunteer to come join us for the battles that are coming up, and in particular the ones over these bills that we've been talking about.
Yeah, thanks, Garrison. And our next fly-in will be coming up in conjunction with the Health Rosetta Fest in September. We will have a steering committee meeting that'll be open to anybody, whether you're a member of the DPC Coalition or not, September 10th, and a fly-in to visit Capitol Hill the afternoon of September 10th and September 11th. And then the Rosetta Fest starts on the 11th. And we're working with Dave Chase and his group at Health Rosetta, bring a couple of speakers from the Hill to talk about these bills and what's going on in Congress. So again, dpcare.org is where you can go to find out information and sign up. And we look forward to having you September 10th and 11th in Washington to, as Garrison put us, continue to push these rocks up the hill, and literally push yourself up the hill, and join us to leave some shoe leather and lobby our legislators on Capitol Hill to make sure we pass the Primary Care Enhancement Act and the Medicaid Primary Care Improvement Act this year.
And then Phil, can you mention any last words and the DPC Frontier?
So, yep. Thanks for the hat tip toward DPC Frontier earlier. That's been a labor of love for me for about 10 years now. The most recent blog post on there talks about a discussion I gave earlier this year with Lee Gross's conference at Docs for Patient Care, focusing on conflicts of interest. And I think family physicians especially understand all the conflicts of interest that come about in the regular system and lead to compassion fatigue. And we need to keep that in mind and tell our stories in DC and elsewhere, and make sure this becomes less of a problem going forward, not only for ourselves, but for the rest of the country.
And just so that you are aware, there is a blog that's going to be accompanying this podcast episode at mydpcstory.com, where I'm going to also have attached to this episode what is the Larry Green study. You can actually read the questions that are the patient-centered, basically feedback on a primary care doctor office's experience. It is a survey that is patient-centered and is so important. You can also find the links to both of the bills that Jay has mentioned, as well as the link to the Milliman study and episodes where Dr. Bliss, Dr. Eskew, and Jay have all shared on this podcast previously. I'm also going to link Dr. Bliss's article that he wrote for dpcnews.com, where he spoke about his experience in February and the actual steering committee meeting recording. So you can take a listen to that to see what is a steering committee all about and how important it was for independent DPC doctors to be at the table. So with that, thank you so much, everybody, for joining us today and sharing your takes on the current status of direct primary care, especially when it comes to Capitol Hill.
Thanks, Mariel.
Thank you.
If you have any questions or comments on the episode, or for Dr. Bliss, Dr. Eskew, or Jay, head on over to the MyDPC Story SpeakPipe, our podcast voicemail line. You can find our voicemail anytime by going to the contact page at mydpcstory.com. For even more DPC stories, practice updates, and exclusive recordings on DPC, become a community member at the MyDPC Story Patreon. You can find the link on the homepage at mydpcstory.com. Look forward to hearing from Dr. Jeffrey Shookman of White Olive DPC in Woodland Hills, California next week. In the meantime, stay informed, stay healthy, and keep telling others about DPC. For more about DPC on the daily, check out dpcnews.com. Until next week, this is Mariel Concepcion.